Hello, everyone, and welcome back to the Rest Isn't Orthopaedics and our 11th episode. And I'll introduce Prof. Johansson to begin with.
Hi, everybody. We've done the first 10 episodes of the Rest Isn't Orthopaedics so that they really would serve as a textbook, an audio book of non-surgical aspects of multidisciplinary care. But our nerve went in the last episode, and we invited Professor Matt Costa to give us a definitive surgical view of the game. And we all face the need to explain things to patients when they come into the wards. And one of the topics that people ask you questions about, they ask me questions about, and staff as well as patients and their families ask questions about, so the pros and cons of different forms of anaesthesia. So what we thought we would do would be to invite Professor Iain Moppett, who's Professor of Anaesthesia and Perioperative Medicine in Nottingham, and Chair of the Centre for Research and Improvement at the College of Anaesthetists. But more importantly, is sort of always around. Every time I go to a meeting about hip fracture at a conference or to a research meeting or trying to run some sort of audit work on hip fracture or indeed other forms of perioperative anaesthetic care, Iain is always there in the meeting as the voice of anaesthesia for this group of patients in the UK. So very much somebody who can give us a powerful evidence-based opinion of what's going on and explain it to the general public as our podcast seeks to do. So welcome, Iain.
Well, and hi, Anthony. Thank you very much for having me.
Lovely to meet you, Iain. And I guess as a new F1 in trauma and orthopedics, one of the first things they teach us is a nerve block or a fascia iliaca block. And we learn all the landmarks and how to do it. But can you really explain what a nerve block is to, I guess, myself and the general audience, and why we do it?
Yeah, good question. So a nerve block is basically putting some local anaesthetic around the nerves that supply the hip. And the reason why we want that to be done for folks that have broken their hip is that hip fracture is really, really painful. And it's really painful when people move. And if we can put some local anaesthetic to the nerves that supply the hip, then we can make it more comfortable. And sometimes that's about some of that pain comes from spasm of the muscles which are overlying the hip. Some comes from the fracture moving against itself. So that's what we're aiming to do with a nerve block, is just put local anaesthetic, same as when you put local anaesthetic in to numb the skin or for dental procedures or anything else, to put that local anaesthetic around those nerves with the idea that we take some, probably not all, but some of that pain away, such that importantly, before someone's had their operation, that they can move around more comfortably. When I say move around, that's things like being able to sit up, that's things like being able to be toileted, moving around for X-rays or other parts of their care. And that's the what of what we're doing. Just put that local anaesthetic in the right place to make things more comfortable, and that's the why. It's fundamentally about making things better for patients, particularly before they've had their operation. And it's actually one of the better evidence bits of hip fracture care. We know that it is associated with the reductions in complications for patients, and particularly one of the things which we all worry about is patients developing delirium, both probably because it makes it less painful, and also probably because it means that patients require less in the way of morphine or other opioid drugs. And the good news is that thanks to a lot of work around the country, actually blocks are getting put in much more often. My colleagues in the emergency department have been trained up, and they're brilliant. And they see this is an emergency thing to do, and they get these blocks done in recovery. In the emergency department, hopefully even before they get to you on the ward.
Yeah, I think I've seen a couple of, especially all of the patients who need anticoagulation, or get them done by the emergency department here in Cardiff, and it's great to see it done. And I guess just moving on to the operation itself, I know there's a couple of different approaches. So I know we've got general anaesthetic and regional anaesthetic. Can you really help me and us to understand what the main differences are and how you approach the conversation with patients.
Yeah, so the easy way, and I guess perhaps the way that I explain it to patients, is that there are two options. They can either go off to sleep with a general anaesthetic, so they're fully asleep, or they can stay awake with an injection in their back, which makes them go numb up to about sort of their belly button. And from and that's broadly for a lot of patients. That's what I explain to them, that's the choice that they're making, because in the end, it probably doesn't, on average, it doesn't make much difference, or it probably doesn't make any difference in terms of a patient's sort of short or longer term outcomes, which one they have. But some patients will prefer to be asleep, and some patients, if they're offered the choice, will prefer to be awake. And that's largely a personal choice. There may be reasons where we favour one or the other, but that's essentially the choice which we're offering to patients. And not every patient can we have that conversation, because a significant number of patients who've broken their hip aren't in a state to understand what those options are or really to choose. So we have to make the choice for them. But that's the broad choice: going to sleep and therefore being unaware of what's going on, but therefore also having to go through the process of waking up afterwards, or staying awake. Right? And some people prefer one, or some people prefer the other.
And with all of these, and with the general and regional anaesthetic, is I guess one approach better than the other, or are they equally as effective?
This is one of those things where if you ask different enough anaesthetists, well, in fact, if you ask two anaesthetists, you'll probably get 5 different opinions. My take on my reading of the evidence is that in general, on average, we can't show that it makes any difference to things that matter to patients in terms of whether they get up, whether they go home, whether they survive in the short or the medium term. So that, in my view, you'll get people who tell you other things, but that's my take on it. There isn't overall a difference. There are some people where we might say one is better than the other, and there are reasons why a general anaesthetic might not be the right thing for an individual, and there'll be reasons why a spinal anaesthetic might be not the right thing for an individual. As you can imagine, you might have someone who's, if we're going to be doing an injection in someone's back, if they've had lots of operations on their back previously, we're probably pretty unkeen to trying to put needles through their back. Equally, there's reasons why some people where a general anaesthetic may not be the safest of the options, but there's very few patients where we say you must have a general anaesthetic or you must have a spinal anaesthetic.
And I guess with those groups, so I know you mentioned people who've had previous spinal surgeries. Are there any other major groups who can't have one or the other approach?
I guess the one that comes up quite a lot is patients who are taking anticoagulants, and whether they can have a spinal anaesthetic, because one of the things we worry about, quite rightly, with having needles around near someone's spine, is the risk of them getting a blood clot around their spine and causing injury from that, which is a really rare complication, but we do worry about it. So one of the questions which comes up, as I say, is patients on warfarin or on DOACs like rivaroxaban, essentially, thanks to some of my colleagues, and these are evidence in some of the, certainly the national guidance that we've got in the UK from the Association of Anaesthetists, we've got some pretty good guidance around saying when it is safe to do a spinal anaesthetic on patients who have been taking anticoagulants. I say whether that's warfarin or more commonly now the DOACs. And within the process of care that we provide for most patients, at 24 hours, we generally view that it's safe to go to theatre, it's safe to have a spinal anaesthetic, if that is the right thing for that patient.
And what about people with chest disease, Iain?
Oh, that's an old chestnut, Anthony. There's a school of thought from some of these systems, and I think this is probably right for some patients, saying that by avoiding general anaesthesia, where the patients may not breathe quite as well as when they're awake, that they would prefer spinal anaesthesia, and therefore they avoid those issues. Equally, there's a school of thought that says actually for some of these patients, what they need, what they'll actually benefit from having some controlled ventilation, some controlled breathing for them during a general anaesthetic. And similarly for sort of stable disease, things like emphysema, and chronic obstructive pulmonary disease. Again, you'll get different anaesthesists telling you absolutely firmly that one or the other is the right thing to do. And some of that does come down to the fact that there will be individual patient differences, where individual patients you go, actually, I'm more leaning towards this, but also differences in the skill set and the sort of experience of the anaesthetist, that they actually find that they can manage patients with bad chest better with a general anaesthetic, whereas their colleague the next day may completely reasonably say they find it better to manage those patients with a spinal anaesthetic. So patient, clinician, and individual sort of interaction, like all the patients that you see. I can give you the averages, but then it comes down to the individual.
When a patient comes back to the ward, what do, I guess, myself as an F1 or the nursing team and the physios really need to look out for from an anaesthetic point of view?
I'd like to hope that you broadly can't really tell whether they've had a general anaesthetic or a spinal anaesthetic, in the sense that the patient should come back to you as good as they're going to be, regardless of the anaesthetic they've had. Now, clearly, if a spinal anaesthetic makes it not only makes people go numb, it means that the motor nerves don't work. So while the spinal anaesthetic itself is active, which is usually only an hour, 2 hours, but sometimes can be longer, then they may have weakness in their legs, which may be obvious, it may be less obvious. So there is perhaps a little bit of caution if you're going to try and get someone out of bed the same day, which is probably a good idea. Just make sure it's done appropriately with a physio to make sure their legs are moving and they know where their legs are. So that proprioception bit, that can be an issue. But other than that, the issue after whatever form of anaesthesia they've had is that they should be coming back from the recovery room in as good a state as they can be, such that they've got a sensible blood pressure, they've got a sensible hemoglobin, they're not nauseated, and there's a sensible management plan, because it doesn't matter whether they have a general anaesthetic or a spinal anaesthetic, they've just had an operation, and the anaesthetist will have almost certainly put another nerve block in theatre, which will help with that pain. But that's not going to last forever. By the time it particularly gets to the next morning, they need to have a management plan there for managing that pain. But we do know that hypotension, so low blood pressure after surgery and anaesthesia, is common, and lots of people have tried to sort of find the golden bullet that makes it not happen, but it does happen. But that's probably the thing to look out for. And like the whole of hip fracture care, delirium, really common, and the evidence, there's not much evidence that it's really any different beyond perhaps the first couple of hours when you have a spinal anaesthetic or general anaesthetic. So again, it's going to be the things you don't go away blaming the anaesthetic when there's the whole host of other things which may be influencing whether someone has delirium on that first post-operative day.
Yeah, I think that takes us very nicely to one of our first podcasts on delirium. Just a quick plug to listen to it if you haven't already.
Yeah, it's fascinating. It all seems incredibly simple, Ian. And I remember back in 2013, you and I were part of the anaesthetic sprint audit that we looked at everybody coming through with hip fracture in the UK over the course of several weeks, and looked at the complete variation in what was going on. Some hospitals, everybody was getting a spinal. Some hospitals, nobody was getting a spinal anaesthetic. There was huge uncertainty. But what that threw up was a really clear picture of what was happening and where the uncertainties were. And you mentioned the Association of Anaesthesia's guidance on hip fracture. We'll put a reference to that in the paperwork behind this podcast, because that's grown out of the conversations we had back then, and it provides an incredibly authoritative, carefully thought through description of the detail, the technical detail of anaesthetic care that complements what you've told us really, really well. So thank you very much for everything you've been able to say.
It's been my absolute pleasure.
Yeah, thank you very much, Ian. It's been really lovely and really informative.
Thank you.
And thank you, everyone, for listening. We'll have many more episodes out soon. I think we've got one on anticoagulation and one on Parkinson's in the works. So I hope you're looking forward to that and see you very soon.